Good day, guys. Today I'll be talking about postpartum hemorrhage, a very, very important topic in terms of a disorder that leads to a lot of maternal morbidity and mortality, especially in the developing world like Nigeria, where I'm living. So, this is the outline I'll be using. So, let's go into it. So, by definition, postpartum hemorrhage is defined as excessive bleeding following delivery greater than 500 mils if it's a vaginal delivery and greater than 1,000 mils or a liter following cesarean section. There are usually two types. If it occurs within the first 24 hours, it's referred to as primary or in other words, early postpartum hemorrhage. Then if it occurs from 24 hours of delivery to the next 6 weeks, it is called secondary or late postpartum hemorrhage. So it complicates about 5 to 8% of vaginal deliveries. Is the most common cause of excessive blood loss in pregnancy and is the most common indication for blood transfusion in pregnancy. There are many other causes of blood loss in pregnancy like antepartum hemorrhage, like ruptured ectopic pregnancy, like miscarriages, first trimester miscarriages. These are all common causes of bleeding or hemorrhage in pregnancy. But postpartum hemorrhage is the most common form of obstetric hemorrhage generally. And this obstetric hemorrhage, especially postpartum hemorrhage, is the leading cause of maternal mortality here in Nigeria. So the causes or the etiology, we use the mnemonic the four T's. The first T stands for tone, which denotes uterine atony, by far the most common cause of postpartum hemorrhage. Second T is trauma, which we refer to as obstetric lacerations, the next most common cause of postpartum hemorrhage. The other one is tissue, which is due to retained placental tissue. While the fourth T, which is less common and we're not going to spend much time talking about it, is coagulation defects, which is denoted by the fourth T, thrombin. So uterine atony. Uterine atony basically is the lack of the contractile force of the uterus. Normally, when a woman delivers, the uterus is supposed to, the uterine smooth muscle fibers are supposed to contract, and this contraction occludes the exposed bleeding blood vessels on the placental bed. So once this doesn't occur, those vessels remain open and bleeding can continue profusely. An inability of the uterus to contract following delivery is called uterine atony. So there are many predisposing factors or risk factors. For example, excessive uterine manipulation, maybe from difficult delivery, like manipulation for shoulder dystocia or forceps delivery. If you manipulate the uterus too much, uterine atony can occur. Also, there could be uterine overdistension. For example, if there's twins or if there's polyhydramnios, which is an excessive amount of amniotic fluid, it will overstretch the uterus. And without overstretching, the uterus may not be able to contract post-delivery. Also, prolonged labor where the uterus has been contracting for an abnormally long period of time than it's normally used to. After such a prolonged labor, if the woman is able to deliver, the uterus may quote unquote become tired and weak because of prolonged contraction due to prolonged labor. Another cause is gram multiparity, which is a woman who has had five or more pregnancies or deliveries. Such women, their uterus are usually very lax, weak, and once they deliver, the uterine fibers are not strong enough to contract post delivery. Another common cause, especially in this part of the world, is uterine leiomyomas or fibroids. These fibroids are fibrous tissue that do not contain any smooth muscle fibers. If they are present in numerous amounts, they may interfere with the ability of the uterine smooth muscle fibers to contract. Another one is operative delivery, such as forceps delivery. This is similar to the uterine manipulation in the sense that use of forceps is a form of uterine manipulation, and doing so will definitely predispose to uterine atony. Oxytocin use, especially during induction of labor and augmentation of labor. The oxytocin, as we all know, stimulates uterine contractions. And if that is done, especially if it's done non-judiciously or anyhow, uterus can be overstimulated, become tired after delivery, and may fail to contract and become atonic. We also have the uterine infection, what we call chorioamnionitis. This is commonly seen if the patient had premature rupture of membranes and the uterus is exposed to the external world, predisposing to infection. So the infection within the uterus can prevent the uterus from contracting adequately. And finally, we have abruptio placentae. Abruptio placentae is a condition where there's premature separation of the placenta. It's one of the causes of antepartum hemorrhage or third trimester vaginal bleeding. What happens here is that blood from the separated placenta finds its way into the uterine muscle, and in doing so, cause it prevents the uterine smooth muscle fibers from contracting adequately because the hemorrhage or blood has seeped in between those fibers, and because of that, they can't contract adequately, and in the process, they lead to uterine atony. So we'll talk also about obstetric lacerations. A laceration is simply a tear. It can occur along the genital tract, such as the vulva, vagina, cervix, or uterus. They are very common in precipitous delivery, where precipitous delivery is defined as delivery whereby that has occurred less than 3 hours after the onset of contractions. So that is very, very quick. And those kind of deliveries can cause a lot of damage as the baby passes through the birth canal. Uncontrolled delivery, if the birth attendant does not control the descent of the baby's head as the mother is pushing, that uncontrolled descent may cause a lot of trauma as it's coming down. Operative delivery, like we mentioned in forceps delivery, this type of delivery may be traumatic because of the excess manipulation using the forceps, so it can cause or predispose to lacerations. Another cause is, which is quite obvious, is delivery of a large infant, especially macrosomic babies. The large infants, as they pass through the birth canal, can cause a lot of tears and damage due to the difficulty in delivering such babies. And such babies even may require operative manipulation to even deliver them. So they are a very, very common cause of obstetric lacerations. So the other cause is retained placental tissue. The most common one is what we call placenta accreta, which is a form of moderately, or not moderately, excessively adherent placental tissue, what we refer to as morbidly adherent placenta. Normally, the placenta is supposed to easily come out of the mother or the uterus or separate from the uterus, but once it's morbidly adherent, a form of it is called placenta accreta. Okay, so the other ones include manual removal of the placenta. It's obvious that if a patient requires manual removal of the placenta is already morbidly adherent. If the third stage of labor is not properly managed, so the components of active management of third stage of labor include: one, the administration of uterotonic agents once the anterior shoulder of the baby is delivered. Two, the use of controlled cord traction to deliver the placenta. Three, the early clamping of the cord. So particularly if controlled cord traction was not used to pull out to remove the placenta, it can predispose to retained placenta. You diagnose retained placenta via ultrasonography, where you see an echogenic uterine mass. So coagulation defects in the clotting system. There are many causes that are acquired while in pregnancy, such as abruptio placentae, severe preeclampsia, eclampsia, and IUFD. Other causes that are non-acquired in pregnancy include von Willebrand disease, thrombocytopenia, and even leukemia. All these cause clotting defects that can cause postpartum hemorrhage. So common clinical features. So historically, the patient, or you may be told that the patient has been bleeding per vaginum after delivery. A typical scenario is a woman has just delivered. She's happy. Everybody has congratulated her. She's been taken into our ward, and the next thing you are called, doctor, doctor. The patient who just delivered is bleeding. She has collapsed. Her bed is soaked. She's feeling dizzy, and so on. So usually there are complaints of bleeding PV. You can estimate the amount of blood loss based on the blood stain seen, whether on the pad, whether on the bed, whether on the ground, or however it may be. The other symptoms and signs that will be based on how much blood is lost and whether the patient is in hypovolemic shock. So that includes dizziness, fainting, weakness, palpitations, or even difficulty in breathing. These are all symptoms of blood loss, hypovolemia, and even shock. So this is a small illustration of how you can quantify the amount of blood loss generally. So you can see a stained sanitary towel is 30 mils. A soaked sanitary pad is 100 mils. Totally soaked bed means about 1,000 mils of blood is lost. If it's a soaked bed and blood is even stained on the ground, you can estimate that about 2,000 mils has been lost. So if you examine the patient, if you do a general exam, generally the patients are confused, they are drowsy, they may be unconscious, they may be pale, they may have cold, clammy extremities, which are signs of anemia and hypovolemic shock. Cardiovascular exam may show tachycardia, low volume pulse, hypotension, respiratory rate may show tachypnea, the abdomen may show a flabby, poorly contracted uterus if uterine atony is the cause. If you do a vaginal exam, you may see evident vaginal bleeding. You may see the vagina or vulval lacerations. You may see the retained placenta still inside the introitus or even retained placental tissue. There may also be cervical lacerations if you really, really explore the uterus and explore the vagina and examine. So how do we treat? So basically, this is a small step step by step guide on how to manage a patient who presents with postpartum hemorrhage. So the first thing you should do is to call for help. You cannot do it alone. Call whoever is nearby and available, whether it's the doctor, whether it's the nurse, the midwife, the attendants, or even patient relatives. Do not do it by yourself because you won't be effective. Add two white blood cannulas and administer crystalloid for rapid volume replacement to treat shock. The patient in shock, apply anti-shock therapy via the standard anti-shock therapy regimens. You should group and cross-match about 2 to 4 units of blood because these patients may be in acute need of blood transfusion or will eventually need a blood transfusion sooner rather than later. You should transfuse the patient as needed. So if they are in shock, you need to replace blood immediately. If you have been able to arrest the bleeding and they are still anemic, you will need to administer blood or transfuse. At the same time, after doing that, you can also do a bedside clotting time. This will help you rule out the presence of coagulopathies. They ask for the placenta and check for its completeness. An incomplete placenta may suggest retained placenta. You should evaluate for uterine contractility by palpating the uterus and seeing whether it's firm, well contracted, and one sign to show that it's well contracted is that the fundus of the uterus will be at or below the umbilicus, which is the 20-week size. Then you should also administer oxytocin or uterotenics in general, whether oxytocin, ergometrin, or even prostaglandins, especially when you especially when you find that the uterus is not well contracted. So you should give 40 units in 500 mils of normal saline and let it run at 60 drops per minute. This is usually the regimen given. Mind you, this fluid is given separate from the fluid the crystal is given for your volume treatment of hypovolemia. Then next, you explore the vagina and cervix and even the uterus. This is to check for any bleeding obstetric lacerations in the vagina, the vulva, cervix. Okay. You also perform a uterine massage if it is you have discovered that the uterus is not well contracted. You should do that every 20 to 30 minutes and assess whether the uterus is well contracted. So this is how you do a abnormal uterine contraction. The non-dominant hand is placed over the fundus of the uterus and the dominant hand is placed into the vagina and onto the uterus, the anterior wall or the anterior fornix, and a compression force is given across both hand surfaces. As we said, you do that for 20 to 30 minutes and reevaluate. So if there are obstetric lacerations, provide adequate analgesia or anesthesia because you want the patient to be as calm as possible so that you can effectively control bleeding by repairing those lacerations. You should insert a deep pad into the vagina so you can stop uterine blood from obscuring your view. You should begin repair above the apex of the tear. That is a standard, guideline or practice when repairing obstetric lacerations. If you discover that the laceration is extending into the uterus, then you should abandon your suturing and prepare for a laparotomy so that the extension can be repaired per abdomen. If you see a hematoma, you should open up the hematoma and arrest any bleeding points. So for a reclaimed placenta, you should remove the placenta manually. And an indication for manual removal is if the separation of the placenta has not occurred after 30 minutes from delivery. But if the patient is still bleeding, ensure that you initiate manual removal of the placenta immediately. But if the patient is not bleeding, once 30 minutes post delivery has passed, initiate manual removal of the placenta. If manual removal of the placenta is not successfully removing retained placenta tissue, you may need to do a careful suction or manual evacuation using an oval forceps or even with a curettage or a curette. So if bleeding is persistent, there are some measures you may take. You may pack the uterus with gauze. You may do radiographic embolization of the uterine vessels, and you may do a laparotomy. So you should counsel the patient on the need of a hysterectomy because hysterectomy is the definitive treatment for uncontrolled postpartum hemorrhage. Other things you can do in a laparotomy include pressure occlusion of the aorta, uterine artery ligation, internal iliac artery ligation, a P-Lynch brace suture, or if all those fail, a hysterectomy. We should always do our best to preserve the childbearing status of the patient. And even if she's unable to consent, we should assume that the patient will still want to maintain childbearing. So let's talk about secondary postpartum hemorrhage. So the most common cause is due to subinvolution of the placental bed. So the placental bed is supposed to start reducing in size and shrinking, but this may not occur. The shrinkage is supposed to occur alongside the shrinkage of the uterus or subinvolution or involution of the uterus to its pre-pregnancy size. It could also be due to retained placental fragments or even blood clots. So possible causes of subinvolution include an abnormal placentation. Maybe the placenta was not properly positioned. There may be uterine infection, endometritis, especially postpartum endometritis. There could also be to gestational trophoblastic disease, which is rare but a common cause of secondary postpartum hemorrhage. So in secondary postpartum hemorrhage, a common management schedule is to first do an ultrasound to exclude retained placenta tissue or maybe blood clots. Then you should do uterine compression and massage. You can also give oxytocics such as oxytocin or uterotonics such as oxytocin, ergometrin, and prostaglandins. You can also give blood sputum antibiotics to treat endometritis. So the primary prevention include early booking and regular ANC. ANC will help, see antenatal care will help see possible problems that may predispose the patient to postpartum hemorrhage. Then during the third stage of labor, manage the third stage of labor actively using the three components that I mentioned before. The first one is administration of the uterotonic after delivery of the anterior shoulder. Second one is early cord clamping. And the third one is the use of control cord traction. So secondary prevention is to properly identify high risk pregnancies. So if you can identify the high risk pregnancies, you can anticipate that they may develop postpartum hemorrhage, and you can make all necessary precautions to prevent it. Then you should also prevent and treat anemia in the antenatal period because an anemic patient can decompensate from postpartum hemorrhage, and the mortality of postpartum hemorrhage is higher if the patient is already anemic before delivery. Then for tertiary prevention, we should treat early and promptly because late treatment is definitely going to increase the morbidity and mortality from postpartum hemorrhage. So thank you very much for listening.